Okay, so I'm going to talk more about the broader applications of VR in healthcare and how kind of both sides, the clinical and the VR, maybe have got a few things still to learn. Who am I? That's a really good question. I'm very multidisciplinary. I was originally a chiropractor, and then for various reasons, I then took a degree in computer science and a PhD in VR, so I'm kind of a fully paid up geek now. But I work right across the clinical and VR side in healthcare and rehabilitation. I'm not working on my own. I'm embedded in the games department, actually, but part of a team of about 30 VR researchers. This is my core team, postdocs and PhD students. And the work I'm going to talk about is my work, it's their work, and also drawing on the work of some of the collaborators we've got around the world, and also just stealing a bit from other people as well to illustrate some of what I want to talk about. It's a huge subject. I could do lectures, I could do a course on this. Oh, I do a course on this. But I'm just going to skim the surface. I want to get you thinking about some things you might not have thought about before. Start off with, what are the areas we use VR in health applications? And the answer is, they're myriad. There are so many of them. And I'm going to just touch on a few to give you some examples of the sort of places we use VR in health. Firstly, physical rehabilitation, sometimes known as motor rehabilitation. This is where you often get things like physiotherapy after a stroke or after you've had an accident. This is upper limb rehabilitation. In the top image there, you can see one of my colleagues working with Leap Motion. Leap is really good for very detailed finger movement, precise gestures. Things we call finger fractionation tasks for stroke patients are great for this. So something like this type of tracking is really good for hand rehabilitation. In the bottom image there, we've got some work of my colleague Vaughan, who's working with shoulder rehabilitation. Now, shoulders are quite different because in order to understand what's happening in the shoulder, we not only have to know where the arm's moving, but we also have to understand the rotations at the joint. So a very different tracking challenge than using hands. But then we've got the lower limb, and this is different again. The top image is, some of you might be familiar with Motex Force Link's big Karen systems. We're working with military rehabilitation centres with amputees and complex trauma. And at the bottom there is our own installation in Portsmouth, and we're looking at ways to help stroke patients. Now, the interesting thing about walking is you need space because people need to walk around. So you'll notice in both of these that we're using treadmills, and in gait rehabilitation in VR, which actually isn't a new field. We've been doing this for about 10 years, and it's been around for a lot longer. But we tend to use treadmills, and we interface those with large screen VR because at the moment, HMDs and treadmills do not mix well. Somebody wants to solve that for me, I'll be very, very happy. But of course, VR doesn't just help the body. We've heard a bit from Charles already and Mel this morning about how it can help some of these psychological aspects. I think Charles did some of my talk for me, which is great, so I can skim some bits. But again, Skip Rizzo's work over in California, working with post-traumatic stress disorder, he's recreating not just things like virtual Vietnam in the visual and auditory sense, but also those scents and smells that people can work with their therapists to overcome some of those triggers. Similar work, Virtual Reality Medical Centre have been doing this for about 10 years in clinical practice now. VR for phobia treatment is really effective. You can create quite realistic, immersive scenarios and then present specific fear cues in graded exposure therapy. And they're seeing some really good results from this. Mel Slater, if any of you went to his talk this morning, is doing some fantastic work on embodiment. Charles already mentioned this, work with depression, embodying an avatar, giving compassion to a distressed child, and then switching over so you become embodied in the child and receiving that own self-compassion from the adult self. Some really interesting work, and the results are great. You might be less familiar with VR for pain management. Now, a pioneer in this work was Hunter Hoffman's work with something called Snow World, where he was using VR to immerse and distract children with very severe pain while they were undergoing dressing changes, an excruciatingly painful procedure in hospital. And immersing them in VR was enabling them to reduce the amounts of morphine they were using and decrease their pain levels. Jury's still out on precisely how this is working, but they have done fMRI studies, so brain scans, and when you're in VR, the pain centres of the brain are less active, so there's something really interesting going on with VR and pain. We're doing some work in a different area of pain. We're working with amputees and phantom limb pain. This is where somebody who's had a limb removed is still feeling pain in the missing limb. Now, it's known that motor visualization, sort of imagining the missing limb, can help to manage this type of pain. So we're working taking EMG surface muscle signals, similar to what Charles is doing with Face Tech, and using them to drive animated arms to help with that visualization and to help them to manage pain. But, of course, healthcare is not just about the patients, it's also about the clinicians. And there are myriad options for you to look at training and education options in the clinical side. So, for example, we're doing a bit of work with a project called Life 3D, using 3D printed models and visualizations of molecular interactions for students of biochemistry and pharmacology to allow them to have a really immersive understanding of how those molecules are interacting in the cells, in the drug interactions, and even inside the human body. You've got companies like Touch Surgery who are addressing the problem we've got of surgeons who they might come in when they're training to observe surgery, but they often are at the back, they can't see what they want to see, they certainly can't stop and rewind and have another look. But using immersive applications, especially VR and AR, allows them to explore those surgical processes, to understand them in a much more three-dimensional way, so by the time they get into the operating theatre, they should be a lot better and more proficient and learn much faster. We're also working actually with a company called Imatech, who are experts in infection control in hospital, looking at how we can use VR to improve both the engagement with training and also the retention of learning. And this is an example from some of the hand washing training we're working with. So why do we use VR in healthcare? VR is cool. We're techies. We're all here because we love VR. But there are much better reasons than that for using VR in healthcare. Firstly, like with the pain work, it's engaging, it's distracting. If you've got a patient, if you've ever had therapy yourself or worked with somebody who needs therapy, people don't engage with it very well. It's often very boring and repetitive. It might be painful. People are perhaps anxious, they're going to fall over or hurt themselves, and they tend not to fully engage. Put them into VR, and they're much more interested in what's going on in the VR and really not focused on the therapy. That's their secondary kind of awareness, and the primary awareness is focused on the VR, so you can get a lot more out of them. You can also give them real-time feedback, much more than having a therapist just sitting there going, yeah, Wendy, you did that really well. Nice exercise, do it again. In our amputees, one of the things amputees have to learn is to control the stump muscles in order to control a prosthetic arm. And traditionally, they get feedback, if any, on a little kind of spike graph thing. If you can take those muscle signals and feed them into Unity, which we do, when they get the muscle contraction right, the virtual hand will open or it will close, so that by the time they get their prosthetic, they're much more intuitive in their use of that prosthetic and the muscles are ready for it. It's safe, or a lot safer than some other ways of doing therapy. So if I've got a patient who's had a stroke and she's no longer able to cross a road safely, I'm not going to take her out to a busy junction and see if she can get across. But I can do that in VR. I can make a junction, I can decide how wide the road's going to be, I can set the duration of my crossing, I can even decide how many cars are going to come through or how many people are going to come across the crossing towards her that she has to get around. So she can gradually train to do that. So by the time I put her out into the real world where the risks are, I'm more confident that she's going to be able to do that. It's controllable. We've looked at the acrophobia here. You can precisely design a VR application, not just for an individual patient, but even dynamically during that application's use. So you've got intelligent algorithms. So in this instance, we're working with heart rate monitors and just looking at something called heart rate variability, which is quite a good indicator of stress and anxiety. If the variability goes up, they're probably a bit more anxious, so we reduce the level of the fear exposure cues. If the variability is less, so they're less anxious, then we can increase the fear exposure cues and accelerate them through that exposure therapy. Data. Academics love data, and clinicians love data too. It's very useful. It tells us not only about whether patients are doing their exercises, it tells us how well they're doing them, how often they do them, and importantly, whether there's any correlation between how they're using our VR app and how much better they're getting. It's very easy to write data collection into your VR apps, and it's really useful for generating metrics for the clinicians. But VR's much more than this. I like to call it the VR pharmacy. Last year at the Games for Health conference, Professor Pam Cato, in answer for the question, does VR for health work? She said, it's like a syringe. It depends on the content you put in it. And that really resonates with me because I think VR it's like a pharmacy full of ingredients that are really useful for healthcare. But often we don't really know what they are, so we kind of chuck a bit of everything in. And people are probably going to get better, but we don't necessarily know which ingredient made them get better. So some of the work we've been doing is looking at some of the ingredients. When we interact with the hardware and the software, it changes our perception and behaviour. We've heard some of this across other talks today. We change the way we feel about ourselves, about the interaction, and we even change the way we move. And we can leverage this to get better applications. First one I want to talk about is something called visual flow or optic flow, and this is actually where I first came into this field. Now, this is the information we get when we move through an environment. Our peripheral vision sees movement, and we interpret this as our self-motion. You might have sat on a train in a station and seen the train next to you pull away, and for a moment, you're not sure, is it me moving or is it the train next to me? I can see some nods there. That's because the visual optic flow is so dominant that the minute we see it, we interpret it as self-motion. And we can leverage this in VR. There are a couple of really interesting properties about visual flow in VR. First one is that when we move in VR, particularly on a treadmill, which we do a lot of with walking VR, our self-motion perception is about half our real movement. So if I'm walking at 1 metre per second, it actually feels like I'm moving at about half a metre per second. Now, for gamers, this is really annoying because it feels like everything's too slow and you want to speed it up. But for patients who are already anxious and think that moving fast is going to make things hurt, this is actually very helpful because it's quite calming and reassuring, and you can perhaps get them to do more than they would otherwise. But you can take this even further. We've done some studies on messing around with the rates of optic flow. And if you have somebody to walk, say, 1 metre on a treadmill, but they only walk half a metre in the virtual world, so you've slowed it right down, what happens is that they pick their walking speed up by about 20%. Now, bear in mind, this is patients who think they're already walking at the top of their comfortable walking speed. And what's particularly interesting is that they don't realise they've got faster, so it's not associated with that anxiety of getting faster. So again, it's one of those ingredients that we can pull out and actually do something useful with. Audio is often neglected, particularly in healthcare VR, and I am so thrilled to see so many good talks about audio this week. Most of you will already know that music and sound effects will influence our mood and behaviour, but you might not know that that change in mood and emotion changes our physical movements as well. So if our mood is low or calming, we'll bring our energy levels down and move perhaps slower and more calmly and controlled, which might be a good thing. Or we might want to bring it up and bring that energy up to get kind of more energy into a rehabilitation process. But again, you can take it a bit further than that. Intuitively, we know that changing the beat of music changes how we move, but we can study this quite precisely. So, for example, in one of the studies, we looked at people's baseline, what we call cadence, the speed they step at, and we asked them to step at their comfortable speed, and then we gave them a tempo that was about 25% above that. And what happens, again, you get about a 15% increase in walk speed from people who already think they're walking at the speed they want to walk at. And like with the optic flow, they don't realise they're doing it, so it's not associated with that same sense of anxiety or fear of pain. Scaling of movement. I harp on at my students, as they'll tell you, about getting the scaling of movement in VR right. Get your scaling right, get your objects right, map your movement. We use a lot of non-standard input devices, and I hammer on about getting the scaling of your movement right. And then, when it comes to healthcare, I completely contradict myself. Because in healthcare, sometimes we want to deliberately misscale or mismatch to get out some behaviours that we want. So, for example, here we have Vaughan's Virtual Orchard. Now, he works with people with frozen shoulder, lost the word there. Frozen shoulder. When you've got frozen shoulder, you want to move less and less because when you move, it hurts. The problem for the clinicians is that we need them to move more. We need them to move past the pain. So if we put them in the virtual orchard and there are apples around them that they need to reach out and touch, they'll tend to go for the ones that are in what they know is their safe space. However, if you move the collision box, the bit that's going to give you the feedback for interaction, just beyond that object, then they're going to reach a little bit further. They're visually quite happy it's in their safe space, but we can get that little bit more movement out of them. So a little bit of a trick that we can use to get them to move more. We can use a similar trick for somebody who's perhaps got a very stiff neck. So if I've got a patient and I want to really protect their neck movement, I might, for every 5 degrees they turn in VR, I might give them 10 degrees of virtual rotation. Conversely, if I want to encourage them to move a bit more, I might do that the other way around. So they'll give me 10 degrees of movement, but I'll only allow them 5 degrees of virtual rotation. So we can, and I would say a caveat here, do this under clinical supervision, but we can use these ingredients and these components to get the behaviour that we want from the patients, and to do it in a way that they don't realise they're doing it and they're much more willing to engage. Finally, in this part, I want to talk about environment cues. The content of your VR experience is much more important than you might think, not just about being pretty, but this first one, the objects. In the orchard, Vaughan discovered that when you change the appearance of the object, it not only changes the accuracy with which people can reach them, but it also changes the quality of movement and how much they're stressing or not stressing their body as they reach towards them. In the middle one, I'm not sure how well that's reproduced on here, you can see we've got quite a sci-fi environment for this walking rehabilitation, which is quite cool and engaging. But the problem is it's got no real-world reference objects. So it's got no chairs or cars or doors or things that we would recognise and be able to scale ourselves to. And if we don't have those, we don't have a sense of depth or distance. In gaming, that's not a problem, but in rehab, sometimes that sense of depth or distance or speed is going to be really, really important. So you have to think about designing the content to match what you're trying to do. The last one, peripheral cues, very closely linked with the optic flow phenomenon. We judge our speed perception not just by general optic flow, but also by kind of the frequency of these particularly vertical peripheral cues. If any of you are drivers and you've approached a roundabout and you see those little white lines painted that make you feel like you're going too fast, so it makes you slow down. Well, visual cues in VR can do the same thing. So if we're moving and the vertical cues are packed closely together, we've got a sense of speed and urgency, and we might slow down or we might be energized. If we space them out, then it brings a sense of calmness and much slower movement, which might be what we want, and it might not. The point being that you need to design for these ingredients to get the behaviour that you want. Seem to have lost. That's it. Okay, so maybe you're a clinician, maybe you're a developer, you've got a great idea. How do you go from there to getting patients better, to doing something that's going to be a good VR healthcare app? Now, again, there's a whole course I could teach on this, and we've got probably about 5 minutes. But just to give you a little bit of a sense of how it works. If you're a clinician, you probably start, there's a clinical need that isn't being met by your current treatments. So you'll define what the rehabilitation outcomes are going to be. You'll hopefully engage a good developer and create a VR application that will have a task that works towards those rehabilitation outcomes. And you're probably particularly interested in the usability for the patient, whether it's acceptable in the clinic or the home, and whether its efficacy. Is it doing what it set out to do? If you're a developer, I'm hoping, delving a little bit into some of the ingredients of VR. You understand the technical potential, and you're starting to identify some of these behavioural modifiers that VR can have, and you realise there's a great application for healthcare. And so at this point, I hope you'll link up with a clinician, and again, you'll develop a VR application, focusing, because it's what you're good at, on the quality of the content, the performance of the system, and how people are going to interact with it. Now, both of those ways are great, and we've had some brilliant applications come out this way, but we've also had an awful lot, a proliferation of quite poor VR health applications, where they're not necessarily getting the best outcomes, but sometimes even doing VR and health a disservice because they don't do it very well. They're a bit of a gimmick, but they're not actually great. What I would suggest that we should be doing, and I know there are some people here who are doing this and it's fantastic, is putting these two things together much, much earlier. So you bring together the people who have the technical insight, not just the developers' insight, but also understanding how VR works in our interactions. Put them together with the clinicians in a co-design process with the end users, and then have this kind of iterative cycle where we're balancing the ingredients that we know can make a difference with the rehabilitation outcomes. And then what you get is an optimized healthcare application, which is not only good for patients, but it's good commercially as well, because that's what will give you the standout that makes your application work better, be better, and ultimately is going to help your reputation commercially. So I'm almost certainly out of time, because I could do about 5 hours on this, so I am going to leave you with that point. But myself and my colleague Vaughan are going to be around for the rest of the Congress, so if you have got questions, do feel free to approach us or grab my email or my Twitter. I do tweet intermittently, but I will respond if you tweet me.
Obviously an experienced lecturer, though, because you've actually finished with 2 minutes left.
Oh, that's
so
impressive.
Does anybody have a question that would prompt? Right, these two were the first hands that went up. So the lady with the red top on, and then the chap with glasses over that way, but we'll get to that when we get to it.
Hiya. I realise obviously you're doing it more on the clinical side, but there has been some VR games that have been looking more on the awareness side. Do you think there's more that can be done for the awareness, or especially for mental health difficulty side? Is there more that VR could do and more explore?
That's a really good question, and the short answer to that is yes. I mean, I don't know if you saw, for example, I always get the name wrong, the Autism Society. They did a lovely VR experience on what it's like to be autistic. We've been working with an artist who suffers with severe anxiety and created an experience called the Panic Room, which we use infrasound for that to get people to understand what it's like to feel a panic attack. So, yeah, I think VR is incredibly powerful and uniquely placed to put you in the place of somebody with a condition that you don't have yourself but you want to understand. So, yes, I think there's lots of potential there for that.
Great, and one more over that way.
Thank you, Wendy. Really interesting about the audio cues and the environment cues as well. Have you looked at all, or you or the team, into any tricks that you can create through haptics or haptic feedback with in medical applications, and how that can actually, being able to sort of reach out with your hands and touch things and getting that feedback, how that can trick the mind or help with any kind of medical.
Again, the short answer is yes. I'm always very excited about haptics because I think the whole point of VR is it needs to be multi-sensory and multi-channel. And we've got several haptic devices in our lab, and most of them don't quite do what I want to do. So I'm just so excited about where ultra haptics are going, and a couple of other companies we're looking at. We're looking at a couple of areas where touch is particularly important, and one of them, interestingly, is with the amputees. There's been some great work done on amputees that shows that if you combine motor visualization with some way of getting to imagine touch on the missing limb, then that's much more powerful for recovery. And we've got one of our PhD students is working on precisely that. He's working on touch and the creation of a sense of touch, both real and virtual, and how that might impact that experience. And I think there are a lot of other areas where touch is vitally important. So yes, please keep developing the haptic stuff, guys, because we want it.
Fantastic. Well, yeah, we better call that it. But yes, thank you so much, Wendy. Really amazing stuff.